Thank you so much. A very good afternoon to one and all. No financial interest. So when we do phakic IOLs, post-operatively, what do we check? We check the vault, and ideally it should be between 250 to 750 microns. So that is the distance between the anterior surface of the crystalline lens and the posterior surface of the phakic IOL. What happens when the size is undersized? So the vault is very low and there is a greater risk of an anterior subcapsular opacification. Even though we have the newer phakic IOLs with a central hole, usually we get vaults even up to 150 we can still monitor. But if the vaults are really low, then this is a very grave risk that we are going to look at. So let's look at a few cases. So this was a patient I had operated in 2014, and you can see the very high myopic astigmatism the patient had. Patient came back to me now 10 years later for cataract surgery, and the thing was that she had a high astigmatism of 3 diopters and a -3 of a spherical component. So first thing is you should always stain the capsule with trypan blue. And this patient had an astigmatism, so we are using the Verion digital markerless system. So while removing the phakic IOL, okay, you have to see that the wound is not damaged or injured. So this is a 2.8 millimeter incision. So put in viscoelastic with sodium hyaluronate and chondroitin sulfate to protect the corneal endothelium, and with a hand-over-hand technique using a toothed forceps. A McPherson forceps will slip. So use a tooth forceps and you can easily remove it through a 2.8. You don't need to enlarge the incision. So then you go ahead and do a perfect capsular excess. Remember, this is a very high myopia patient. This is a soft cataract, so you can easily tumble the nucleus and emulsify it with the gentle phaco-emulsification. Irrigation aspiration with a bimanual is also extremely simple, but because it's a high myope, sometimes you can have a very deep chamber, so you need to be careful about the LIDRS phenomenon. Now look at that line which you can see on the right side. Probably this lens has been there for 10 years and that has caused a thickening of the line, so it could look like a ZD. For the first time, I probably thought that there could be a ZD. So I went on and checked also. So this was a smart toric, Ultima smart toric lens for the patient, because with a -3 diopter sphere and a 3 diopter cylinder, you will not get it in any other way. And it's a thick lens. So remember, these lenses are always to be put the right side up. If you invert it and put, you will get a refractive surprise. And it's a bulky lens, so you'll literally need to fold it and put it into the capsular bag. So now I'm checking all the areas for any kind of zonular dialysis, but that was just a thickening of the capsule. You align the lens properly in the desired axis, which is 0, 180 for all smart torics, and post-operatively, patient did very well. This was another patient done 6 years ago, again a very high myope. See, high myopes usually also have a greater tendency to get early cataracts, but this was not an anterior subcapsular cataract. Remember, in these patients, optical biometry, you can use directly the power that you can get because it's an optically clear medium. You don't need to make any changes. So I've used a 1 diopter lens. This patient wanted a flax procedure. So with the presence of the phakic IOL, when you do flax, there are certain changes that you make in the settings. First of all, the incision depth and the energy settings need to be changed. Also, when you are doing a flax, when the femtosecond laser falls on the phakic IOL, the OCT considers the surface of the phakic IOL as the lens. So you need to manually bring down the 3 bubble marks onto the surface of the lens capsule to get a proper capsulotomy. Again, there are a lot of deflections of the laser from the surface of the phakic IOL. So you can see even the pupillary edge is not clearly delineated. You need to manually make it proper so that you get a correct nucleotomy. Again, you need to stain with trypan blue. It's very important. Now, this was in fact my first case, and this was also a IPCL, which is normally a little more rigid than the ICL. So my thought process was that suppose I need to extend the incision while removing it, I can have a wound leak and further problems during surgery. So in this case, what I did was I rotated the phakic IOL vertically. I'm sitting temporarily for the surgery and did the phaco-emulsification underneath the phakic IOL. Now, as I removed the capsulotomy flap and did the phaco, please watch carefully what is happening. There is an extension of the capsulotomy, there's an anterior capsular tear. So you need to be all the more careful. You have to prevent any fluctuations in the chamber because we don't want it to have extension into the posterior capsule. And with a hand-over-hand technique, I could remove it through a 2.8 millimeter incision. So the take-home message is you don't need to extend the incision. You can easily remove it through a 2.8, so you don't really need to go in underneath the lens and do a phaco. And in all these cases, always do a visco fluid exchange. Do not allow the chamber to collapse, and the IOL is put at 90 degrees. So again, patient did extremely well post-op. So literature says that because of the laser beam that is deflected from the optic of the phakic IOL, if you do flax in such cases, there are a greater risk of an anterior capsular tear, so you need to be careful. So why does cataract occur? Early cataract is probably because surgical trauma, and late cataract is because of a very low vault and subclinical inflammation, disruption of the blood aqueous barrier. And over time, we all know that there is a decrease in the vault size because of a age-related increase in the lens thickness also. This could cause anterior subcapsular opacities. So it's a mid-peripheral area which usually could have a very close proximity to the lens. So ideally what you need to have is a complete separation between the phakic IOL and the crystalline lens. How often does it occur? So this was a meta-analysis of cataract development after phakic IOLs, so which says is approximately around 9.6%. And if there's a pre-existing cataract, obviously the progression rate is very high. However, with the ICL, only 1 to 2% has been reported to have a clinically significant cataract, especially with very high myope and a higher age. So the first 2 to 3 years are very important. So when do you decide to do a cataract surgery? If the vision drops 2 or more lines, or a patient has increase in the glare symptoms. So if you look at the percentage of ICL explantation, approximately 13% of explantation is due to cataract. Again, as I said, biometry, you can use SRKT or the Barrett Universal 2 is what we usually use, and there are no changes that you need to make. Somehow, they have found that there could be changes in the axial length and the readings also. However, it does not affect the IOL power calculation. And how can we prevent it? How can we counsel our patients? We need to explain to them there is the risk of complications, how it differs from LASIK, and how you can manage these challenges even later. And they need to keep coming to you for a regular eye checkup, not only for looking at IOPs, cataract, as well as the fundus evaluation. So with good meticulous pre-op workup and good surgery, you can have very good results. Also, I would request you all for a humble request for your support, as I would be standing for member scientific committee in the forthcoming AIS elections.